My name is Robert Lookstien. I'm the Executive Vice Chairman for the Department of Diagnostic, Molecular, and Interventional Radiology here at the Icahn School of Medicine at Mount Sinai. I'm also serving as the Course Director for the Venous Symposium over the next 2 days. I'm very proud that we're having a Venous Symposium. Last year was our first year with dedicated content on what I'm going to call deep venous disease. It was a very, very successful inaugural year with some really fantastic presentations by nationally regarded faculty and what I would consider some extremely educational live case presentations. These are all currently available on the website archive via YouTube. This year it is more of the same, but there's a lot that's been happening in the international deep venous space. We're going to be talking over the next 2 days, and these are going to be 2 morning sessions here in this auditorium, again, specifically about deep venous circulatory disorders, deep vein thrombosis, chronic venous occlusions, which is becoming more and more readily diagnosed, and we're finding more and more patients in all of our cardiovascular practices that are suffering with symptomatic central venous occlusions, most typically in the lower extremities. There's a tremendous amount of research involving venous compression syndromes and how those relate to deep vein thrombosis and then again symptomatic chronic venous occlusions. Tomorrow we're going to be taking a deep dive into the treatment of pulmonary embolism, specifically acute pulmonary embolism, as there's been a true grassroots movement, not only in this country but internationally, about team-based approaches to treat this disorder. And then we're going to finish up tomorrow with a focus on inferior vena cava filters, which has become a very, very controversial therapeutic over the last decade or so. So just a little bit of background, then I'm going to ask my moderators for this morning to come up and sort of get the session kicked off. But deep vein thrombosis is a true global cardiovascular epidemic, not just in this country where we see over 500,000 cases annually, but the incidence of the post-thrombotic syndrome, which is where a patient is chronically suffering after an acute DVT, again, typically with lower extremity edema and varicosities, is estimated to occur in up to 500,000 patients annually as well. These are correlated with venous ulcers, which is a tremendous healthcare burden, and it's estimated that globally up to several billion people have symptoms of chronic venous stasis disease annually. PE, on the other hand, the devastating, potentially life-threatening manifestation of deep vein thrombosis, again, is diagnosed in over 500,000 cases annually. We are certainly seeing an epidemic here in New York City, where the incidence of obesity, diabetes, and sedentary lifestyle are contributing to a very, very high prevalence of this in this major metropolitan area. We obviously know that most symptomatic PE originate from the deep veins of the lower limbs, and the majority of our patients that present with an acute PE have evidence of DVT when they are in fact imaged. Pulmonary embolism is actually the leading cause of in-hospital mortality in North America, and there's a tremendous opportunity to improve that statistic in and of itself. We're going to talk a lot tomorrow morning about what efforts can be made at a local, regional, and national level to decrease the rates of mortality associated with acute PE. But you can see here that more people are unfortunately succumbing to acute PE as compared to car accidents, breast cancer, and HIV combined, which is a very, very sobering statistic. There's been a proliferation of endovascular therapeutics to try and treat acute PE. I can humbly say we do not have consensus about what the best therapeutic is yet. And I think we have some of the nation's leading thought leaders that will try and give some direction on how we can take this science forward and hopefully lead to best therapy for our patients in the next 10 years or so. Again, I alluded to this previously, but the incidence of venous compression syndromes, whether it's the lower extremity with the May-Thurner lesion, the upper extremity thoracic outlet, and then even the nutcracker syndrome, which can affect the left renal vein, have been correlated with DVT and pulmonary embolism. And we're using more and more imaging diagnostic studies to be able to diagnose this. The therapeutics are controversial to say the least. especially in minimally symptomatic patients, or we're going to try and create clarity for that as well. And then lastly, inferior vena cava filters. Last decade, there was seemingly a huge groundswell of enthusiasm for this technology, with over 100,000 cases being placed in the U.S. Annually. This was actually correlated well with an incidence of, unfortunately, adverse events associated with this implant. And so now we're in the second decade of the millennium, obviously, and there's been a lot of clarity on who exactly should get this, when and how, and possibly even whether or not one of the implants is a safer implant. We have 7 implants commercially available in the global market right now, and I think there's a lot of strong opinions about which one people want for their patients specifically. So without further interruption, I'm going to ask the co-moderators for this morning, Aki Sista and Keith Sterling, if they want to come up and take a seat on the nice little benches we have set up here. But obviously enjoy the morning. Sorry for the typo. We have national expert faculty. We have very, very interesting live cases that we'll get to right after the morning lectures.